Thank you, sir. The outset, I will thank the organizers as well as the chairpersons for this opportunity. I'll stop my video to get better speed, and I will straight away start with the talk. I have to finish this in maybe 17 minutes, so I'll skip through. And if time permits, I will complete the entire presentation. Otherwise, I will touch through the most important aspects. The scope will be definition, classification, ECG approach, and rest of it will all be through examples. And if time permits, we'll discuss some exotic-like cases. The bradycardia is defined as a heart rate less than 60 minutes in adults. You have to remember that the rate cutoffs vary with age, and newborns and young children, it is very different. It can be due to disorders of impulse generation or conduction, rather propagation, or a combination of both. So if we classify it in anatomical terms, we can have bradyarrhythmias due to problems at the sinus node level, like sinus bradycardia, sinoatrial exit blocks of varying degrees. At the atrial level, in the form of atrial standstill, which is not uncommon, but probably under-recognized. The AV node level, which is the more common thing we familiarize, again classified into first degree, second degree, or the third degree blocks. And we have to be familiar with terminologies like escape beats and escape rhythms. Escape beats are actually non-sinus beats that follow a pause. Because the normal sinus beat didn't come, another focus has escaped. And when the escape beat sustains the heart rhythm, it's called an escape rhythm. So in a single slide, I will summarize the aspects of ECG approach. We have to analyze beat by beat. Our focus should be on the P wave, and we have to define the relation between the atria and the ventricle, that is P versus the QRS. If there are no P waves, we should look for escape beats, or instead of P, whether there are any fibrillation or flutter waves. Putting everything together, then we have to define the rhythm, because parts of the rhythm may be different at the onset of the strip versus the end of the strip. Sometimes more than one diagnosis may coexist. Everything should be kept in mind, and the diagnosis should also include the sites of impulse formation, like junctional escape rhythm, atrial escape rhythm, as well as subsequent conduction, like for example, with right bundle branch block or with left bundle branch block, and so on. Apart from this, we have to attempt to localize if the block is in the proximal conduction system, so-called suprahisian level, above the his, versus in the distal conduction system, that is below the his, because this differ in prognosis. Suprahisian rhythms are generally dependable, narrow in QRS, whereas distal ones are slower and not very much dependable, and has a higher risk of sudden cardiac death. You should always meticulously hunt for clues towards underlying diagnosis, which may be hyperkalemia, hypothyroidism, hypothermia, intracranial bleed, or anatomical disease like corrected TGA, which are actually responsible for the bradycardia. Then only our ECG approach becomes complete. So going on, we'll discuss at every anatomical level, starting with sinus bradycardia. So in sinus bradycardia, we have P followed by QRS with a normal PR interval, which is 120 to 200 milliseconds in adults. Usually there is no distal conduction blocks and the QRS is narrow. And if there is a distal conduction block, we should also describe that it's a sinus bradycardia with so-and-so, like RBB or LBB, or if it doesn't fit into either, we should call it intraventricular conduction defect, IVC. Like in this example, we have a heart rate of 38, the P-axis is suggestive of a sinus rhythm, and PR interval and rest of the intervals are normal. So it's a sinus bradycardia. And we should also mention that there is LVH and deep T inversions, which may be compatible with a hypertensive intracranial bleed, depending on the clinical scenario. Then only our analysis becomes complete. Sometimes the sinus node fails to generate any impulse and the junction escapes. Then we use the term sinus arrest. Like in this ECG, for example, the QRS is very narrow. The P waves are not very much related to the QRS. Some of them fall, like my arrow shows, before the QRS, while some of them follow the QRS. So they may or may not be related. So what we can be sure is that the rhythm is an escape rhythm coming from the junction because it's a narrow. The retrograde P may be due to the junction or may be an independent atrial focus. The same patient was made to stand and this ECG was recorded. Now we are more sure that the P is driving the QRS and the P axis is suggestive of a non-sinus rhythm. So this is probably an atrial rhythm. You can call it escape rhythm, atrial escape, because the junction didn't come. And he was made to walk through a TMT, and now the sinus has taken over. So just in a asymptomatic patient, a lack of sinus rhythm essentially may not be pathological. It may come out during exercise. And reason for this is the vagotonia, which slows the sinus rate. Junction may escape, and even Wenckebach type of AV block may be seen. Whenever vagal tone reduces, like with exercise or during coughing, sinus node tends to function normally. It's common in athletes, young adults, and is usually benign and doesn't warrant a pacemaker. So our duty is to identify whether vagotonia is underlying cause of the rhythm or is it a true sinus node pathology. Coming to more complex and luckily very, very rare scenario, like Mobitz type 1 SA exit block. Unless we have familiarized ourselves with this pattern, it's more likely that we tend to miss this diagnosis because SA node potential cannot be seen in the ECG. That similar to PR interval in the AV node conduction, SA to P interval is not existent. We cannot see it in the ECG, and hence the cause of confusion. So we have to use indirect clues towards the Wenckebach, that is Wenckebach at the SA node level. So these are progressive shortening of the PP interval. As I show in this arrow, the PP interval is shortened here. And PR interval should be constant, and then a P drop resulting in a pause. And this pause should be less than twice the shortest PP interval, which is usually the last PP interval. So in this particular case, it's a 4:3 SA exit block of the Wenckebach type, causing a progressive shortening of the PP interval with a constant PR interval and a drop which is less than twice the shortest PP interval. So these are rules of Wenckebach, and we have to apply them in the ECG to bring out the diagnosis. Usually, no particular treatment is needed for this scenario either. Then comes the Mobitz type 2 SA exit block, which is easier to recognize because there is a sudden drop in sinus beat resulting in a pause, and the pause is a multiple of the basic PP interval. Like here, after 2 beats, the sinus has paused, P has dropped, and this pause is a mathematical multiple of the basic PP interval. If I count, it's just like around 4 big boxes versus 8 big boxes. So this is a Mobitz type 2 exit block. When you don't have a pattern where basic PP interval can be found out to call it as a multiple, then probably we are dealing with what is called a sinus pauses. They don't follow any rule, mathematical rule. They just occur randomly, and junction or any other focus may escape, terminating the pause. Like here, you don't have a P wave at all. It's junctional escape beats. Whereas in the middle strip, you have a sinus beat capturing, followed by a long pause. And during the pause, junction has escaped. And this is common in the scenario of tachybrady syndrome, where intermittently patient may be having tachycardia. Commonest tachycardia in sick sinus syndrome or tachybrady syndrome is atrial fibrillation again. And in between, it is punctuated by periods of bradyarrhythmias. Not all pauses may be primary pauses. Sometimes the diseased sinus node manifests as a tachycardia termination related pause, as in this case. You have a flutter going on, and suddenly the flutter decides to terminate for whatever reason, and the sinus takes a while to escape. And that results in a pause, and if it's long enough, it can cause syncope. Here we have to focus on the management of tachycardia, but not with drugs, but with ablations, and see whether we can avoid a pacemaker for some years at least. Eventually, the sinus node disease progresses and bradycardia dominates. Coming to the next level, it's a junctional rhythm. We don't have any P wave preceding the QRS, whereas we have regular consistent P waves, inverted P waves following the QRS, and the RP interval is constant. Instead of PR interval, now we are talking about RP interval, which means that it's a junctional escape rhythm with retrograde atrial conduction. Also seen as an incomplete right bundle branch block. So here is the ECG where sinus has not come at all, sinus arrest and the junctional escape and retrograde VA conduction. In such ECGs, we have to meticulously look for P waves because absence of P waves may mean that the atrium is diseased, atrial standstill or atrial paralysis as it is called. I'll come to that later. And sometimes sinus beats and escape beats play hide and seek with each other. Like one escape beat from the junction followed by a sinus beat from the sinus node. You can see the P waves in the lead V1 to be clear here, my arrow here. So such beats are called capture beats. After an escape beat, the sinus is able to capture the ventricle again. And in this pattern, it is called escape capture bigeminy. It's one of the reasons for bigeminal rhythm. And here we have another junctional escape rhythm. This happened to be a young boy with restrictive cardiomyopathy. And in this ECG, we have to look meticulously for P wave, as I mentioned, and we can find that there is no P wave at all. Rather, we are seeing some myocardial disease in the form of fragmented QRS and repolarization abnormalities, deep symmetrical T wave inversions. So this was a case of atrial paralysis, and it has to be recognized because it carries a very high risk of thromboembolic events, even higher than that of atrial fibrillation. After finishing sinus node and the atria, now we'll focus on the AV node itself. And usually we have conduction abnormalities causing AV nodal blocks. By definition, first degree AV block is a misnomer because nothing is blocked here. It's just a delay. Every P is followed by a QRS complex, but the PR interval is more than the defined normal, which is 200 milliseconds in adults. But the one-to-one P-QRS relation is maintained. And if you have a PR interval more than 300 milliseconds, it's almost always sure that the level of the block is the AV node. Odds for that is described in the original paper as 39. And if there is a wide QRS, it indicates additional infrahisian disease is there in the form of East-Purkinje system or bundle branch block involvement. So this is a classical example of first degree AV block localizable to the AV node. Usually the proximal blocks have a better prognosis than the distal blocks like infrahisian disease. Higher degree of block is a Mobitz type 1 block where at least one P fails to get conducted. And when this happens after a progressive delay in the AV conduction, it's called Mobitz type 1 or the familiar Wenckebach phenomenon. The PR keeps on prolonging and finally culminates in a dropped P. After that, the sequence repeats. In the classical Wenckebach, it's called decremental increments, which I will not explain here. But the simple clue here is the last conducted PR. If you compare with the first PR of the subsequent beat, it will be longer. This PR is so much long compared to this one. Because here the PRs drop, they will not get time to recover and its conduction improves a bit, only to get prolonged with each beat further. So it's a long cycle Wenckebach or Mobitz type 1 AV block. Of course, prognostically, it's not very bad. It's more common in normal hearts like vagotonic states, children, during sleep, in athletes. And progression towards higher degrees of block is not common and anyway not abrupt. More ominous is the Mobitz type 2 block, where there is an abrupt intermittent blockage in AV conduction without any preceding changes of the PR interval. It has potential to progress and is always pathological. Like in this case, every third P wave is conducted. Two of them are blocked, 1 year, and third one managed to get conducted with a constant PR interval. If you see the conducted PR intervals, all of them are constant. So there's, in the widest sense, this is also a high-grade AV block, which is defined as two consecutive P waves getting blocked. All Mobitz type 2 blocks are also high-grade AV blocks, and perhaps most of them will need pacemakers unless there is a reversible cause. A distinct entity here is 2:1 AV block. In this case, it is a wide QRS, but it also can be narrow QRS. This cannot be classified as Mobitz type 1 or type 2 just because you can't demonstrate a progressive lengthening of the PR interval. Every alternate P is blocked. But it is indeed possible to classify it as proximal versus distal, rather suprahisian versus infrahisian. If QRS is wide and the PR is normal, probably we are dealing with the infrahisian level of the block, which is more ominous. Whereas PR is long and QRS is narrow, it's likely to be at the suprahisian level. In this case, there is also coexisting right bundle branch block. It's a 2:1 block with wide QRS, and probably there is a bad prognostic sign. Even higher degree is the complete heart block, where there is no relation between P and the QRS. So the PR interval, by definition, should not be there. It's a fallacy. And we want to tell PR interval is variable. It doesn't maintain any constancy. But once we have a complete heart block ECG, this is a congenital complete heart block. That's why the atrial rate appears so high. We have to look for ominous signs. Not all patients perform very badly. Some patients may be totally asymptomatic, but we have to look for high atrial rate, which suggests an increased sympathetic drive and probability that the patient may collapse. A wide QRS escape, which suggests an infrahisian disease, an unstable escape keeps on changing morphology. Repolarization changes in T wave, QT prolongation related to bradycardia, complex PVCs, or presence of syncope. All these place complete heart blocks at high risk. This is an example of complete heart block with wide QRS. Earlier I showed you narrow QRS. This is a wide QRS, and this is an adult ECG, and you can see that atrial rate is very high. It's almost like 135. And single beat is showing a different morphology. Maybe a conducted beat or maybe a different escape, but varying morphology itself is regarded as a higher risk feature. Now, high-grade AV block, it doesn't fit into the already mentioned entities. Randomly, some of the P waves get conducted with a constant PR interval. Like here, you can see one PR, constant PR, and here the same PR is repeated here. All others, PR is varying. So in general, it's all blocked, but some do manage to get conducted. Such a situation is called high-grade AV block. Moving to rarer entities, this is a paroxysmal AV block and ILR tracing with abrupt syncope being the history. And what we see here, all the investigations were normal, like Holter, ECG, everything was normal. So an ILR was put and patient presented with a syncope. We note that in the space of a normal one-to-one AV conduction, suddenly a sequence of P waves get blocked for no reason. And after a while, for no reason, they recover. It's a incompletely understood entity, and it happens for no apparent reason. And it's very hard to diagnose unless you have long monitoring tools like ILR. Even the EP study may not prove of much use in such a scenario. And even unrecognized one is a paroxysmal phase 4 AV block. It's also a phase 4 AV block, but it's always triggered by a cycle length change. Usually it's an ectopic, either from the ventricle or from the atrium. In this case, it was from the ventricle. Post-ectopic, AV blocks ensues. It reflects a diseased His-Purkinje system. The QRS is usually wide, even in the sinus beat. Once you have an ectopic that manages, the sodium channels are always diseased. So they get locked in the phase 4. They don't repolarize fully. And that causes the AV block. It's a rare entity, again needs Holter usually for diagnosis. And very common entity, which I don't want to miss at all being discussed, is vagotonic AV block. We will see this in almost every Holter during sleep, especially in young adults as well as athletes. Importance of identifying it, this is a very benign history and nothing at all needs to be done. Clues are usually seen in sleep, like in this case, it is around 12 o'clock in the night. And the PP interval stretches. Sinus also slows before the AV block. You can see that PP, and here the block is having a very long PP interval. And here the junction manages to escape. And sometimes you can see changes in PR interval or even linky back type of AV blocks. It's important to identify because they almost always never need pacemakers. So this is the vagotonic AV block. Can I proceed, sir? 4 or 5 slides will be there more.
Yeah, you can complete, yeah.
Yeah. Now we have to look ECG for beyond bradyarrhythmias. All of us will identify basic bradyarrhythmias very easily, but we should not miss other aspects of the ECG. Like tachyarrhythmias may be existing in combination with bradyarrhythmias. Sometimes we may get clues to underlying structural heart disease or even effects of drugs like digoxin and all. This is an example of 31-year-old man, congenital complete heart block, on follow-up for more than 2 decades. He presented for the routine follow-up, just to note that QRS is very regular, narrow, but lo and behold, there's no P wave. Instead, we can see that fine fibrillatory waves. So he has gone to the natural history worsening of the congenital complete heart block. His atria dilated and culminated in atrial fibrillation. So this is AF with CHP. There's another ECG showing flutter with complete heart block. It's a regular flutter interval. PP interval is seen here. Regular RR interval also is seen. But the flutter to QRS, instead of PR, we are talking about FR interval, is variable. I have marked it with arrows. The varying flutter to QRS interval suggests that it's a complete heart block existing in the phase of an atrial flutter. Whereas if it's a conducted flutter wave, you will get a constant flutter to QRS interval. This is another example of complete heart block with brady-induced QT prolongation. You can see the distortion of the T waves. The shape has changed. The T peak to T end ratio has changed. QT interval has prolonged. T waves have inverted. All these repolarization abnormalities suggest potential to develop retort states. Such patients are at high risk and need to be identified prospectively at the time of ECG so that they are never sent back. Instead, they are taken to the lab and put a temporary pacemaker at least. This is another interesting CHP, complete heart block. We have regular PP interval, regular RR interval, and no relation between the P and QRS, atrial rate more than ventricular rate. All of them are needed for definition of complete heart block. I will repeat that. Regular PP interval, regular RR interval, no PR interval, atrial rate more than the ventricular rate. So it's a typical complete heart block. As we discussed, atrial rate is much higher. Impending hemodynamic collapse should be anticipated. But more interestingly, V4 and V5 shows very narrow-based peaked T waves. This should ring a bell towards hyperkalemia. And this lady actually had moderate aortic stenosis causing this LVH as well as CKD with a potassium of 7. I'll show you the ECG after dialysis and potassium correction. You can note the T wave, V4 and V5. Not only that, inferior leads are showing now inverted T waves, whereas during the hyperkalemia, they were upright. So this was a subtle clue that hyperkalemia existed and caused this CHB, and her conduction improved after correction of potassium. Is yet another interesting ECG with Mobitz type 1 block, progressive PR prolongation, dropped P, also seen as 2:1 narrow QRS AV block. Interesting thing here is that there is no septal Q. Usually we expect V5, V6 having a septal Q. Instead, you can see deep Q waves in lead 3, and you can also note that T wave is upright across all precordial leads, V1 to V6. These are clue towards a congenital abnormality called corrected transposition of great vessels. This is a 21-year-old man, otherwise asymptomatic, known to have corrected TGA. And corrected TGA is known to cause AV conduction abnormalities. Another rare and more ominous cause of AV block is AV block because of long QT syndrome. The QT interval is so long that the P falls on the ST segment. Because the ventricular myocardium is not fully repolarized yet, the P gets blocked. There is no pathological AV block. It's a consequence of the pathological delay in ventricular repolarization. And this particular kid had deafness, Garber-Lange-Neal syndrome it's called. And in the newborn, this has a very ominous prognosis. 2:1 AV block due to long QT syndrome. And this is my last but one slide. This is a case of alternate bundle branch block. This patient underwent a aortic valve surgery and Holter post-surgery showed right bundle branch block. These are V1, V3, and V5, 3-channel Holter. At around 8 o'clock in the night, he had a sinus rhythm with right bundle branch block, whereas at around 11 o'clock in the night, same guy showing left bundle branch block. This is also a rare entity, maybe less recognized also. It indicates advanced infra-ischial disease. Both bundles are severely diseased, but none are fully blocked. But the rate of progression to complete heart block is so high that this per se, even without symptoms, warrant a pacemaker implantation. This is my last ECG, an asymptomatic 38-year-old man. Apparently, he has sinus bradycardia, first degree AV block, intraventricular conduction delay, probably we don't know RBB or LBB, we don't have precordial leads, and likely having a pan conduction system disease. But if you see closely, the paper speed is 50 millimeters. So it's an artifactual bradycardia. You have to always confirm the paper speed before making a diagnosis of any bradycardia, or for that matter, tachycardia either. With that, I complete my small session.